Hello and good evening, everybody. My name's Ed Nandasoma. Welcome to this evening's webinar. Firstly, thank you very much for taking the time to join us this evening. This is our first webinar of the 2023 series. We've got a lot of content coming up, but we thought we'd start with the subject of complaints, which I know is a stressful topic, particularly now in the NHS. This evening, I'm joined by two of our senior medical legal advisors, Dr. Sarah Jarvis, whose background was in general practice, Mr. Gerard Ross, who was a neurosurgeon before coming to the MDU. We've got quite a bit to get through, so we'll make a start very shortly. These webinars are always really improved with your participation and questions. We usually don't get quite a lot of questions, so we can't say that we'll answer them all, but if they're short, clear, on topic, we'll try and get to them. The way we're going to do questions today is to have Gerard in the background looking at the questions, collating them, and we'll discuss them at the end as a kind of panel. If you please use the chat box to put things in, and do that from now on. It gives us the best chance of putting those together. And please be reassured that even if we clear it up in the slides, it's always really helpful to have your input. So with that, and the final thing, housekeeping point, is that we do record these webinars and the content will be available on our website. So if we have to go through something fairly quickly and you want to check back, then please look on our website, on our YouTube channel. It'll be there in about a week or so. So without further ado, what we'll cover today, we'll talk about the frequency of complaints, a little bit about the impact of complaints, the importance of good complaints handling, and also the importance that you and all staff working in your organisation are able to recognise a complaint. We'll then spend a bit of time talking about acknowledging and investigating a complaint and how to write a response. We also know that meeting with a complainant can be quite stressful. It can be a really effective way to deal with a complaint or to resolve unanswered questions at the end, but it does require planning. And we'll also talk about the processes that are engaged if a complaint isn't resolved or that may be engaged. We'll also talk a little bit about what's new at the end, and that's really for those of you who work as complaints handlers in your practice. If you're the responsible person for complaints or practice managers, then we'll talk about some new sources of information about that. So just as an introduction, what do people complain about? Well, these are the number of all reported complaints in the NHS. There are 225,570, which frankly is a tiny number when we think of the total number of interactions there. If you think about the proportion of those interactions that are predominantly in primary care, you'll see that despite the fact that the last year has been a really stressful time for both doctors and patients, the number of complaints is relatively small. Roughly half of those aren't upheld ultimately, and roughly a third of those were made about GPs. And that's always difficult because often the target is the person that the doctor sees as being responsible. So if we move on to the next slide, in terms of what the complaints are about, I don't think any of you will find this surprising. Often they will be about clinical treatment, about appointments, about communication, about kind of staff behaviour, etc. And the prescription issues here, I've kind of put together things that are issues about prescribing errors to issues in relation to repeat prescriptions, etc. Again, given the amount of this sort of activity that goes on every single day in the service, actually, although we know that this is a really stressful subject, we have to put it in that perspective. Next slide. So Sarah, over to you.
Thank you very much. I'm just going to touch very briefly on complaints in Wales, and just to remind you that at the MDU we're very mindful that there are 4 different jurisdictions in the UK. Sometimes bits of law and regulations are different, and I'd like to reassure you that we have jurisdiction appropriate information, so dealing with complaints in each of the 4 countries on our website. If we look at the data from 6 months last year, there were 10,500 complaints to health boards and trusts, which equates to almost 7 complaints per 1,000 residents of Wales. And that's slightly higher than the figures in England, which approximate to about 4 per 1,000 complaints per 1,000 population. And again, just over a quarter of complaints are about clinical treatment, which is the main. The next slide, please. I think it's important that we recognise that complaints can be very stressful and time-consuming for the patients and those who are making complaints, for those who are being complained about, and indeed, you know, when we take advice line calls, it's very evident sometimes that doctors find these things very stressful, especially on the background of a very busy frontline experience at the moment. But it can also be stressful for those who are investigating complaints. And so, as Ed has already alluded to, we're very keen to support those who are involved in investigating and actually making the responses. Thank you. This next slide is a very popular slide here at the MDU because it shows the potential consequences of a single clinical incident. So this multiple jeopardy sets out the various processes that our members may have to face, depending on where they are, from a single clinical incident. And you can see that sort of complaints and so on may be part of a bigger process. And that's why it can be important to get sort of special advice about how to deal with these things, because there can be other sequelae of matters arising from that. The next slide, please. Okay. I think it's important for us to remember that we're obliged to deal with patient concerns, that there are statutory regulations around how we have to do that. And of course, in England, you have the Care Quality Commission, which means that make sure that all registered care providers have to make sure that people can make a complaint about their care, and you can see the legislation there. And I think it's important to remember that complaints can be a source of learning and can drive service improvement. It's often that feedback that we get that makes us look at systems, processes and outcomes to see what we can do to improve. And next slide, please. Okay. So we set out there the legal obligations, both in England and in Wales. And of course, as doctors, we're regulated by the General Medical Council, which provides information for us. And this sets out very clearly in good medical practice, which I'm sure you're all familiar with, you must cooperate with formal inquiries and complaints. I'll now hand back to Ed. Thank you.
Sorry, I was the classic mistake of being on mute. So we talk about complaints. Well, what is a complaint? You can define this in various ways. I think the simplest definition that makes sense is a concern or expression of dissatisfaction about an act, omission, decision made by an organisation, either verbal or written, and whether it's justified or not. And we've highlighted that because the difficult message sometimes is that even if you know that the complaint really isn't justified, it still engages this process which requires a response to be delivered in some way. And we'll talk about how to deal with some of those more difficult situations later, but remember that sort of definition. So we often hear also about formal and informal complaints. I don't like that term so much because it's easy to kind of mix that up between written and verbal complaints, and a verbal complaint can be just as formal as a written one. There is a distinction in the complaints regulations, and this applies in England and Wales really about this, is that an oral complaint resolved within 1 working day to the satisfaction of the complainant can be considered informal. So it means that it doesn't fall under the regulations which set out timescales about acknowledgement, requirements for response, etc. Now, it doesn't really tell you whether the issue is serious or not. There may be an oral complaint that you think is, gosh, that's a serious issue, we need to discuss it as a practice, we need to look at it from a governance perspective, etc. But it may not need to fall under the regulations because you can reassure the patient the matter has been dealt with. For example, it may be a prescribing issue that is intercepted, corrected and dealt with. So the complainant is quite happy that it doesn't need to be put through the regulations, but any written or oral complaint not resolved within 1 working day are all considered formal by the complaints regulations. The importance of that is they must be acknowledged and a written response must be issued ultimately. Next slide, please. So again, to risk of labouring this point, a verbal complaint that's not resolved within 24 hours, that should be managed by your organisation effectively, a note made of it, and it acknowledged in a normal way. And typically where it's an oral complaint, the safest thing to do is to share it with the complainant and get them to agree that's what the complaint is about. Now, there's nothing wrong with supporting a patient put their concerns in writing. Some people want to do that. There's nothing wrong in doing that. What you should not do is say to them, look, you must put this in writing, otherwise we won't deal with it as a complaint, as the complaints regulations acknowledge that an oral complaint is a valid one. The other thing is it can be difficult, but you know, you can quite reasonably seek feedback from your patients, and I know a lot of you will do that in practice, and it doesn't necessarily mean that it's a complaint if it's a gripe, etc. If you're not sure how to deal with it, when you look at something and say, look, this is a very specific concern and we think we should deal with this as a complaint, if you're in doubt, ask the patient or the complainant. So Sarah, over to you again.
Thank you. So the complaints procedure in Wales has many similarities with the English one, but the legislation around it is slightly different, and you can see on the top bullet point that that's the legislation that we have to deal with. And interestingly, the regulations use the term concern, which includes both complaints, but also expressions of dissatisfaction and reports of adverse incidents from staff, so it's slightly more encompassing. And interestingly, there is a difference between primary and secondary care, because for secondary care, it can be considered, NHS hospitals and local health boards have to consider whether it's appropriate to offer financial redress of up to £25,000 where there has been negligence. However, that redress requirement doesn't apply to primary care providers or independent providers of care to NHS patients. Thank you. And the next slide. So when we look at key important points for primary care and dealing with practice, it's important that all staff who interact with patients must be able to recognise a complaint. So, you know, people who are dealing with patients every day, and it's good to empower them to try and resolve what they can do when they can do it. So if we take an example, maybe a lost prescription and somebody comes to the desk and they're unhappy about that, if the receptionist is able to liaise with the pharmacy and get it sorted out, that's great, and you know, you can resolve things. Equally, there may be times where somebody asks to make a formal complaint, and the staff should know how to deal with that. And you should have people then who are able to manage a written response. Often that obligation will fall to the senior partner, and of course practice managers as well will play an important role. And I think a key take-home point here is for your staff to know how to manage an oral complaint, so to take a note of the complaint and to know who to escalate that to. But when you make a note of an oral complaint, it's always really helpful to confirm with the patient that what you've documented is in fact what they're concerned about. And I think that we'll hear later about the Ombudsman, and there are different Ombudsmen in each of the 4 countries of the UK. But there is a general approach which is advised by the Ombudsman about listening carefully, getting clear what the concerns are and what the issues are that need to be investigated, asking the complainant what they want to achieve. Is it something that you can resolve straight away, or is it something that you're going to need to review and consider? And I think managing expectations is important as well, that it may be very easy to deal with a short complaint and to advise that you might be able to turn something around in 2 weeks. However, in the summer holidays, when many members of staff may be off, and perhaps a number of different doctors have been involved in a patient care as well as other members of the healthcare team, it may take much longer to carry out an investigation, and it's much better to be upfront with the patient about how long you think things are likely to be. It's really important that you set out what the next steps are as well, so there's a clear pathway that you're following. The next slide, please. So in England, there's an expectation that a complaint is acknowledged within 3 working days, and also that the complaint should be investigated in a manner appropriate to resolve it speedily and efficiently. So using your resources to try and get things resolved. And we've already discussed the importance of keeping the complainant updated about the progress of the investigation. In Wales, the acknowledgement letter has to be sent within 2 working days, and a response generally within 30 working days. And actually the acknowledgement letter can be a really important part. It's generally best to avoid having a standard letter, and making sure that you've understood what the complainant is saying and that they have an opportunity to discuss how the complaint will be investigated. That can be really helpful, because sometimes you can tease out there what are the really important things in the complaint as far as the complainant is concerned. And the next slide. So there are some technical time limits which apply in England and Wales to dealing with complaints. And generally there's an expectation that they should be raised within a year of the event leading to the complaint, or a year if the matter leading to the complaint came to the notice of the complainant later than the actual incident. However, time limit does not apply if there's a good reason for the delay and it remains possible to investigate the complaint effectively and fairly. Obviously, if complaints are very historic, it may be very difficult to investigate. I think it's helpful to remember that if you can investigate things, then generally it is a good idea to try and resolve things within the practice. The GMC reminds us that patients' concerns should be dealt with, and the GMC doesn't specify any time limits. I think it's important to remember as well that if we're not able to resolve patient complaints locally, there is a possibility that they may seek to get information and to put their complaint elsewhere. And I'll now hand back to Ed. Thank you.
Sorry, so we're going to go through a kind of fictionalized complaint, which has got some kind of common themes in, and really to try and illustrate kind of the different approaches you can take with a complaint. Now I'll go through the scenario, but can I first just remind you, if you do have questions, try and get them in early. Use the chat function to do that and put those in. So returning to this complaint, so think about a patient who's just had a bowel cancer operation. They've got a stoma, and they've got a couple of concerns. They've got concerns that they were not diagnosed promptly. And you'll see there's a patient in the 40s and they're distressed by having a stoma. They've also got a complaint about not being helped appropriately with the stoma bag and not getting the medications they need, adding to their repeat prescriptions. They also say that that they've got problems with the repeat medication system. Again, I say this isn't a complaint from anywhere in particular, but it's the sort of themes we can come in, and it's typical in that you may have one theme that's the really strong theme, and other things that you can see has caused some irritation to the complainant and perhaps has been added. So we talked about acknowledging the complaint. So as Sarah said, this can be a real opportunity. Now, it must be done within 3 working days, and we know that creates a pressure of time, more so in Wales when you've got a time frame of 2, and it's tempting to send out a standard form letter. However, it is, the regulations also require the complainant to be given what they describe as an opportunity to discuss how the complaint will be investigated and when a response will be issued. Now, this isn't the same thing as saying, look, you must have a meeting with a complainant to discuss to respond to the complaint. You can do, of course. This is more about sort of saying to the complainant, look, this is what I understand the issues in the complaint to be, and this is what I plan to do to investigate it. I'm going to talk to the district nurse team. I'm going to get an account from the doctor about your initial diagnosis, and we'll look into the repeat prescription issue. Is that okay? So that's what's envisaged there. And the other really important point, I think, sorry, please, can we bring up the bullet points as well on this slide? So it's if we think about this as, and as I say, that I appreciate this is somewhat of a pastiche, but if you simply say, I'm sorry, you feel the need to complain, we'll respond to your concerns with 10 days. And there were quite a few standard form letters like this, which of course doesn't really confirm that you've understood what the complaint's about, etc., and also imposes a time limit on you that really isn't what's reflected in the regulations and puts you under unnecessary pressure, which can mean that the response isn't as good as you want it to be. So yeah, next slide. So you can say a little bit more than that in not much more time. In a phrase like this allows you to kind of reiterate what the concerns were to make sure you've understood them. In a complaint of the type that I've put up, it's pretty clear, but I'm sure all of you have had those several page handwritten letters where you're not sure exactly what the concerns are. A lot of them are gripes or observational background, and you're not sure, and you risk sometimes putting a lot of effort into the response and the complainant then saying, actually, that's not what I was happy about. The other thing that can be helpful is a reassurance from the practice that care won't be affected while the complaint is ongoing. Now, there is sort of data to back up the fact that a lot of complainants feel their care will be affected. We know in very many ways that doctors really don't think about things in that way, but it is important to bear that in mind as well. Next slide, please. And again, you can set out a bit further how you plan to investigate the complaint and give an expectation of, and I'd say a realistic expectation of when the complaint response might be due. And if there are people on leave, etc., this is an opportunity to explain all of that. I would recommend that you diarise to contact the complainant every couple of weeks if you're beyond the date of response. I say that because sometimes these things very occasionally get forgotten because of the pressures in practice at the moment, and that can be a real problem. If somebody comes back 6 months later saying, well, I complained to you, you didn't respond, I forgot about it, but I'm aggravated again now, please can you respond, and why did you take so long? It can add more complexity to it, so having a system to manage that can help. Next slide, please. And there are a couple of other things that we've set out before. I think we've made the point about setting out the points of complaint to be investigated. We've talked about the issue of complaint response being issued. Where you've got somebody complaining on behalf of a complainant and a consent becomes an issue, it also can explain that you'll continue to investigate the complaint, but you're going to take steps to try and make sure that consent is finalised, but also give reassurance that's not going to delay your investigation of the complaint, but will determine when you can actually disclose it. Next slide, please. Sarah, can I pass back to you?
Thank you. I think it's important to remember that there are many examples of good complaint handling. As we're all familiar with, the practice is the local resolution stage, and of course the Ombudsman is the second tier of complaints handling. And the Ombudsman does have a lot of very helpful materials about approaches to dealing with complaints so that they can be resolved. And we've already discussed earlier that it's important to involve the complainant to find out what they want to achieve, to explain about the process, to keep them updated, and to manage expectations. And I think that's something that we're all very familiar with in the health service at the moment. And I think it's important to remember that the Public Health Service Ombudsman, who is based in England, sets out 3 steps to good complaint handling. And this is step 1. So listening carefully, confirming the concerns, making sure you understand the issues to be investigated. Can you resolve it quickly? And I think we're all familiar that actually the quicker things that can be resolved properly, often that will lead to a better outcome. But of course, it's important that you do have time to investigate and to make a good response. And being open and realistic with the complainant about timescales is really. Next slide, please. So if we look at the letter again, so investigating the complaint, you can see there the 4 points that the patient has raised, okay? And we've highlighted in red there the salient points of each one there now. So you can see that this is a patient recently been discharged and they've had a diagnosis. So you get a picture of perhaps the vulnerability of the patients, the questions about why wasn't I referred urgently, issues with another service. And of course, it's not uncommon for patients to have concerns about different aspects of the health service. So there are concerns there about repeat prescription, and then the fact that they've had difficulty getting through on the telephone as well. So those are the key things that have been identified there. So if we think about how, if we were investigating this complaint, what would we need to do? And I think an important thing here would be an account from the receptionist. They're often the first point of contact with the patient, and you may want to hear exactly what's gone on and how things were dealt with then. Maybe important to take an account from the doctor. Here there's a concern about an alleged delay in diagnosis, so it would be important to go behind the clinical decision making and so on, to seek a review of the clinical management, and that might be important to get the insight and the reflections from the doctor themselves. But often it's really helpful to have a significant event review or a complaint meeting with a variety of clinicians so that you can sit down and look at what actually happened there. And that can often be really helpful in producing a timeline which can be useful when you're making that response. Next slide, please. So in terms of the second step of good complaint handling, as per the Ombudsman, it's really helpful sometimes to share what you're going to do with the patient, and we've discussed that you can do that in the acknowledgement letter, and then to consider what evidence, what sources of information you might need, how you'll evaluate those, and how you'll decide how to deal with things. And it's important to consider who is able to give you some information, which people in the team, or is it, might you need to involve the wider team to get some information. And it's often really helpful to look at relevant guidelines or national standards, such as the NICE guidelines and so on there then, so that you can actually see whether the service that you provided was in accord with good clinical practice. And of course, then sometimes you will have to decide who's going to make the decision about whether the complaint is upheld, either in part or in full. So all of these things should be in the back of your mind when you're considering how you're going to investigate things. Next slide, please. I think it's really helpful to consider how you've looked at the complaint process, and that can reassure the patient very much if you're able to show some objectivity in how you've done it. So if you look at the terms that we've used there now, what should have happened versus what did happen, but you need to be careful sometimes about not getting involved in a he said, she said scenario, but actually the patient's perception is really important, and the complaint response can often be a very useful part to explain things. And I think it's important that you go into dealing with complaints with an open mind, that you don't feel that you're going to, deal with what the staff have said and that you're going to take that as read. But you should give equal weight to what the complainant is saying and to what your staff are saying. And using these objective criteria to try and sort out the clinical issues can be really helpful as well. Okay, I'll hand over to Ed now for the slide on disagreement. Thank you.
Great, thank you. And just as an aside to say, I can see the questions are coming in. They're all raising really important points, so we'll certainly try and address those at the end. Disagreements are really difficult, and by that I mean one thing where, say, a complainant says one thing, your member of staff says another. When you're investigating a complaint, you have to put yourself in a really difficult position of gathering and evaluating that evidence. So there might be something where a patient says the doctor didn't do this at this consultation, and you would be in a situation of looking at the records, getting the doctor's account, seeing that there's a result from a test that would evidence what was being done, and being able to say, look, I've looked at the evidence, and on balance, look, we can see that the doctor did do the right thing, or did do that you're saying that they didn't. Equally, be mindful where there is an absence of evidence. If the patient, if it's simply a dispute about what one person said and another, you might have to say, look, somebody, you said this, our member of staff said that, I've not been able to resolve that issue based on my investigation. This is what we can do to try and solve the problem that you've taken. The pitfalls there are sort of falling into situations such as saying, look, I've asked the practice manager or the receptionist or the doctor, they said this, they wouldn't lie. Now, I'm not suggesting your staff would lie, but in terms of being able to evidence an even-handed and objective analysis of the evidence you've gathered, you've got to acknowledge where you can't resolve it rather than simply preferring one side over another where there's no good reason to. Now, of course, I'm not suggesting you fuel disagreements, because when things are not resolved, it's stressful for all those concerned, and it does increase the risk of escalation. So next slide, please. The other thing when you're presenting evidence is to actually present it effectively. Now, quite often we see lines like this in complaint responses, and when you talk to the doctor concerned, actually the practice has had a really detailed debate about the care. They've heard contrary viewpoints, they've come to a reasoned conclusion, and the skill is really being able to showcase that in the letter. So the next bullet point, please, on here. Yep, next slide, please. Now the slides aren't moving on. Is that just me, Sarah, or is it?
No, I can't see them moving either.
Okay, so I picked this. I'll let Jared try and sort of maybe restart the slideshow, but I picked this example because of kind of my background in gastroenterology. But in this situation, you've got a patient complaining about a delay in diagnosis of bowel cancer. Well, in that setting, if you were to say, look, we've reviewed your complaint, we discussed it at a practice meeting, we looked at the NICE guidance on bowel cancer, here are the symptoms it suggests mandate an urgent referral for bowel cancer. You had you didn't have these symptoms, you presented with constipation, this is what it says about that. We recognize it's a problem and this is why we referred you, but we didn't do it on a cancer pathway because of this. Now, that is a more robust response in that setting. Now, bear with me 1 second. Let me try and see if I can deal with the
Would it be
slide
helpful
issue.
perhaps if I turned and we had a quick chat about writing the response there then? Maybe I can talk about that for a while.
Yeah, you do that and I will try and get the slides up.
Thank you. So much like writing a story, the response should have a beginning and a middle and an end. And it's appropriate at the beginning to introduce yourself, so to set out if you are the person responsible for dealing with complaints, an expression of empathy. So I think it's really important to remember that saying that you're sorry that someone has been upset or has had the concern of the complaint is not an admission of liability. That's a question that we often get asked here at the MDU. And I think it's important to bear in mind that often patients who raise complaints have been feeling unwell, they have concerns, and that expression of empathy goes a long way, I think, to diffuse any frustration and anger. And then to set out an explanation of how you've investigated the complaint. So whether you've spoken to the receptionist, if you've been able to listen to a call recording, if you've held a significant event analysis, all of those things should go in at the beginning of the response. The middle of the response letter then, you should explain what happened. And that can be a really helpful thing to come out of a significant event analysis, is that often you're able to get a timeline, for example, when the results were received in the practice, when they were actioned, when an appointment was sent out, all of those things. And I think it's really important to remember that you must respond to every point in the complaint and to give your analysis. And I think it's important, therefore, that you do identify very clearly with the complainant exactly what the concerns are. It's really important to look at learning points from a practice perspective. There is an expectation in NHS regulations that significant events and also complaints should trigger learning for the practice. And of course, that is really important for those individuals who are involved in a complaint. As we know, doctors have to discuss all complaints at their appraisal process, and having had a really good, robust discussion with colleagues and to see if there's any relevant CPD or learning points that can be identified can be incredibly helpful. So the middle part, explain what's happened, respond to each point, and then cover the learning points or the practice changes as well. And then at the end of the writing the response. It's important to identify what the complainant can do if they remain dissatisfied. And the MDU advice is always that you do whatever you can to resolve things at a local level. So it's really helpful if you say, for example, we'd be very happy to deal with further queries in writing, if you'd be happy to arrange a meeting with the complainant, and we'll touch on that better a little bit more, but also to provide details of the Ombudsman. You must do that to make patients or complainants aware of their right to escalate matters to the Ombudsman if they're dissatisfied with the local resolution process. And I'll now hand back to Ed. Thank you.
So again, this is based on the Ombudsman's principles of good complaint handling. I should probably have said earlier on, the reason we keep referring to the Ombudsman's guidance is that the role of the Ombudsman is to provide second stage review for unresolved complaints in the NHS. So they have the statutory power to judge your complaints handling as well as the clinical service delivered. So it's important to be kind of mindful of what judgment they use. And I think, to be fair to the Ombudsman's team, they have probably done more over the last few years to be a bit more concrete about what good complaints handling looks like, rather than some of the kind of broader statements they've made before. What they say is be clear and compassionate, provide evidence, particularly when you're talking about the clinical care, provide evidence for your rationale, explain whether something went wrong or not, and be clear about your decision as to whether the complaint's upheld or not, and any action you take, and tell complainants about the Ombudsman. And again, I know it seems to be inviting further escalation, but it is a requirement of the complaints regulations that all responses do include that. Now, I want to spend just a few minutes talking about some of the issues which we know cause significant difficulty in complaints and cause a lot of distress to our members, frankly. The first one is where you get a factually inaccurate complaint, what the complainant's saying, that their symptoms were not assessed, or that a history wasn't taken, examination not done. That can be really distressing, as it's often when the doctor's gone an extra mile with a distressed complainant. In that situation, I would say that your factual account is key. And we'll often say, start with your opening paragraph, be conciliatory, set out what you've investigated, but then go on to give a factual and chronological account of what happened. And that might seem repetitive, because you may repeat that in the answers later on, but it's the key to being able to get across what you have found objectively took place, or where it's a matter of one person's account or another, setting out what that person has said. And it's the way of sort of doing it without being argumentative. You're simply setting out the facts rather than entering into that debate. And if you can evidence where that comes from, that's the best way of dealing with that without adding fuel to the fire, as it were, of the dispute. The other thing that's difficult is subjective comments about the practitioner. When they say, oh, the doctor dismissed me, they didn't take my concerns seriously, I didn't think they were interested. Those can be really hard to hear, particularly when, quite often you see from the notes the doctor was really interested. And I think the right way to deal with that is to give a detail of the account of the assessment made and explain the clinical reasoning. If you can explain the reason why you asked certain questions, what you thought about and discounted, what you plan to do, that the fact that you gave it that much thought can really help to illustrate that the symptoms were taken seriously. So that's why that basic account is so important. The final thing is when the patient or the complaint letter makes discriminatory or abusive remarks about staff or the practitioner. Now, the complaint is still live. You must still respond to the complaint, but you can absolutely deal separately and robustly with the discriminatory comments through your practice behavioural policy, give a warning, etc. If it's a recurrence and you've warned before, or it's a threat of violence, you may remove the patient in that setting. Although I know that, we know that you apply a very high threshold for that. Now, the point about this is that, yes, you mustn't remove a patient simply because they have complained. So you can't simply say, well, you've complained about our service, you're obviously not happy, register elsewhere. On the other hand, the complainant can't use a complaint as a smokescreen to essentially abuse staff. these can be difficult. Knowing exactly where the threshold of allowable frustration that you might give them a margin of appreciation for, you know, is really difficult sometimes, judging that from where it's crossed the line. You'll have an instinct for that. You know, we're always happy to talk if you're kind of wondering where it sits on the line and what you can do. So Sarah, can I hand back to you for meetings with complainants?
Thank you. I think it's helpful to remember that actually sometimes meeting with a complainant can be incredibly helpful. It can stop a volley of correspondence and minor things going back and forth. And actually sort of being able to eyeball someone who is saying that they're sorry can be very powerful and can settle things down. I think it's important that if you're going to have a meeting, that is done in a considered way. So what might remain unresolved? Have you got enough time to set up the meeting? Obviously, clinicians are often very busy in the day and you may need to set time aside, and a private venue. And the patient should be invited to bring someone with them if that would be helpful. And it's often really useful to have a note taker to take accurate minutes of the meeting, which can be shared later. We've got a really helpful e-learning resource on local resolution meetings on our website, and that's available to all of our members. So as part of your reflection for your appraisal process, you might want to have a look at the resources that we have there. Have the next slide, please. Okay. So before the meeting, you need to set out an agenda. So what's going to be discussed? Next point, please. How long the meeting is going to last, and that can be quite important to manage expectations, to make sure that you've got enough time to deal with that, and somewhere private where you're not going to be disturbed and for other people to see what's going on. Next slide, please. And who's going to act as chair? It can be really helpful to have perhaps a partner who's not been involved in the complaints, just to take the lead and to make sure that everybody has had their say and that matters have been resolved. And afterwards, it can be very helpful to use the minutes to summarise the discussion in a letter, and then that letter can be circulated to the patient and their supporter and to the staff to make sure that the discussion there is accurate. Thank you. Next point. Again, it would be important to signpost them to the Ombudsman, and as Ed has already alluded, they are the second line of the complaints resolution process within the NHS, and they can seek a review of unresolved complaints related to care which is funded by the NHS. There are 4 ombudsmen in the 4 countries of the UK, each of whom will have slightly different ways of dealing with things. Again, that's something that we can support our members with if they've got specific concerns about that. Certainly, we do sometimes get made aware of complaints only when they've reached the Ombudsman, and if you do get a complaint that's at the Ombudsman level, I'd strongly advise that you pick up the phone to us or send us an email so that we can support you with that. It's important to remember that the Ombudsman can look at several aspects, both the clinical care, so the service provision that's been given, but also complaint handling. And what generally happens is that a draft report is produced, which is used then to give the practice an opportunity to comment on the outcome of the investigation, but we're often seeing as well that there's an opportunity to comment on the intention to start the investigation. So that's something that has become more common recently. So to see whether there's anything further that can be done to get things resolved at a local level. And the next slide, thank you. And if you're asked to comment on a draft report, it's really important that you involve all of the staff who might be involved in that report. It's often the case that perhaps doctors in training who've left the practice by the time a complaint has gone through the Ombudsman, they may no longer be there. There may be locum staff or bank staff that you're using, and it's important that they are also involved in any response that's made there. I'll hand back to Ed now. Thank you.
So to reiterate that in Ombudsman's cases, look, seek advice. Also be mindful that this triggers a duty to tell NHS resolution and the GP indemnity scheme in Wales. Now, those schemes differ slightly in that NHS resolution don't deal with Ombudsman's awards. GMPI might if it's on a clinical matter. However, they still both require cases to be reported. The other thing that I would say is, and I know this sounds a bit obvious, but if you've undertaken to take specific steps following a complaint to implement certain learning points or systems changes, make sure you've done that, because that will be something the Ombudsman will look at negatively if it's not been done, or might sort of take the view that there's actually very little for them to do if you can evidence that those things have taken place. So the final thing we'll talk about today is kind of what's new. Now, the last time we gave this webinar, the draft version of the NHS complaints standard was what was there in terms of what patients should be able to expect from a kind of model complaints handling procedure in the NHS. That was finalised in December 2022. They talked about a number of things. They also talked about apologies, and I think actually made some kind of pragmatic statements of that, you know. And the thing I would say is that quite often you may say, look, I'm sorry this has happened to you, but the care was appropriate, in which case you're majoring on the explanation. Where something has gone wrong and an apology is warranted, make that a fulsome apology. And this is a way to do that, to a proper expression of regret, give a reason for the mistake, or say that, look, this was a simple human error, etc., and explain what you're going to do to put things right. Okay, so in summary, we know that complaints are frequent, stressful, and important. Communicating with the complainant where there are difficulties in responding is really important, and also to understand what the complaint was initially about. It's really hard, but try and investigate objectively and structure your response. Sarah did a section on the beginning, middle, and end. That's not a kind of absolute rule, but if we know that sometimes it's really hard to get started with a response, think of that to sort of get you going. Share learning from complaints, because there's obviously going to be greater focus on that. And if you have a meeting with a complainant, go in there with a plan, think what the issues might be, actively manage expectations, and deal with that there, and be clear about the next steps if the complainant remains dissatisfied. So a really quick section on what's there. Each ombudsman has material on the website. The recent publications are from the English Ombudsman. They're generally good reference documents in terms of complaints handling. So I'd recommend these as starting points. Oops, sorry, that was me clicking something there. So if we go, the thing that's new is the NHS Complaints Standard Organisational Assessment Matrix. Now, that's a real mouthful, and I think this is really only of interest to those of you who are developing and evaluating your complaints procedures. This kind of allows you a way to objectively assess that against these sort of criteria. So that's the end of the presentation. I'm going to stop sharing my my screen there.
Hi everybody, I'm really sorry. I think that my IT caused a problem there. I apologize if it left my colleagues scrambling slightly. I think my wife and daughter may have been watching Netflix. I do have some questions. I can't currently access every question right now, but I do have a list of questions that have been asked. So shall I ask those questions now, guys?
Yeah, there's just one that stood out to me that I'll deal with, because I can feel for a doctor here who's lost the practice manager, waiting a permanent repayment, and obviously complaint responses are taking longer. And the question you've asked is, do we need to still send a written response within 48 hours? Now, the thing to remember is that first timescale, the 48 hours or the 72 hours in England, is really for an acknowledgement. So that's your acknowledgement, just to say, sorry to hear of your concerns. We understand this is what the complaint's about. That's your opportunity to say, look, we're experiencing a lot of issues at the moment. We will take longer than we'd like to respond to your complaint. This is the timescale, and we'll update you. So I just want to be clear on that, because I certainly didn't want to sort of make that more difficult. Jared, over to you.
So one of the questions which came up is something that we are aware of in the MDU and as advisors. It's how do we approach expressions of dissatisfaction which come to the practice through social media? And I guess Although the complainant doesn't specifically mention it, I think we're probably talking about reviews on Google Reviews or comments in Facebook groups, for example. So any thoughts about that? Guys?
Yeah, I think it's important to recognise that social media is with us in all aspects of life, and it can be sort of quite distressing when perhaps members of staff bring these notices to our attention and so on. I think the important thing to remember in all of these things is that you need to behave professionally when you receive these comments, and you have to be mindful of your obligations of confidentiality. So often taking the concerns away from social media, and sometimes you might be able to set up a very blunt message to say, I'm very sorry to hear of your concerns. Here is the complaints procedure on our website. Sometimes it's possible to identify a patient from such a posting, and you might want to reach out to those through conventional means, so not using social media to respond, but to advise that you welcome feedback through the proper channels. And it's important then that you don't breach confidentiality. But it can be very stressful seeing things in print. We recognise that. We're happy to give advice on dealing with criticism on social media, and indeed we've got a lot of resources on our website about that as well.
I think that's an important one, isn't it? Differentiating the feedback in social media from a complaint that you need to necessarily engage with, and the dangers about engagement. Sometimes you might direct somebody to the proper channels and how to complain, and encourage them to complain through that channel so you can respond to it properly. But sometimes there may be circumstances, if they're not prepared to do that, you might just let the complaint drop down the social media feed and not be seen to specifically engage other than that direction to the right channel. Another question was, what must we report to the MDU? Ed, that seems like a question with your...
Yeah, so I mean, in terms of complaints, we don't require you to report them to us. If there is a solicitor's letter and it's a claim that falls to the MDU, and for GP claims, it's either arising from private work or NHS claims before the 1st of April 2019, we'd say, look, you must report those to us, or if it's not us, it will likely be NHS resolution. But in terms of a complaint, look, what we say is that we really want to help you with them, because they, it's difficult to predict the ones that escalate, but we don't demand you contact us. I think that links in with what resources training through the MDU for training. We have 3 things. There's a complaints hub on our website that's got a lot of information on it. We'll have these recorded webinars. There's a suite of e-learning as well in terms of managing complaints, both from if you're a hospital doctor or a GP or acting as a complaints handler. So those are the resources available on our website as well.
Probably reasonable to highlight, though, that the CNSGP, the state-backed indemnity scheme, do have some triggers, as do GMPI, triggers for contacting them, which are always worth being cognizant of. There are certain circumstances in which they would expect to be told about a complaint. For instance, the Ombudsman getting involved would be a trigger for them becoming involved. Let's see what else there is here. Is there anything like the CQC in Wales, Sarah? Anything of a similar?
We've got the healthcare inspectorate Wales, which is slightly different in terms of, where it is in the legislation. So the reporting regulations are not quite as strict, but I suspect that over time that we will mirror very closely what happens in England in terms of notifiable incidents and so on. So, and I'd like to reassure members that when there are new pieces of legislation that come out or new organisations, the MDU website always carries details of that. So it is worth dipping in and out every few weeks just to see if there's anything relevant for your organisation.
Can I ask, have either of you come across particularly good practice in tracking outcomes? So one of the attendees has mentioned that they struggle to keep on top of everything and knowing that the outcomes on individual issues are being acted upon. Have anybody come across systems they've seen used which have helped practices manage that, or any experience specifically related to that?
I think sometimes when practices are preparing their annual returns and so on, for some of them they will hold a meeting to look at themes that have come out, and I think we're all familiar that some of the themes that come out are things that are not within the gift of general practice to sort out. So, for example, waiting times, things like that. But it may be that if new systems have been brought into the practice, that there could be themes around that. And it may be that I think sometimes it's quite helpful to see that if you've made a change, to see if actually you've had fewer complaints, for example, about your repeat prescribing system, if you change things as a result of feedback.
What I was going to add to that as well, Sarah, and maybe Ed was about to do it, is we will be having a new complaint management system coming in for MDU members, which will help people manage that. In fact, Sarah, I think you were heavily involved in producing it, which will help people track complaints. Is that right?
It's in the trial stage with some practices at the moment. We're seeing how it goes and getting feedback from that, but we know this is an unmet need. I think the other point about learning points is actually where there are nuggets that you know are clear learning points, is to implement them as soon as you can before it gets lost amongst all the other burden that you have is probably the sensible thing. I think the system-wide learning has always been a challenge, and that's kind of partly why we're looking at the systems we are.
One question was to do with when do we, this I think will be the last one that we're going to be able to respond to given the time, but when does a complainant become unreasonable? Possibly a harder question to answer, but are there specific times you think, well, we've really reached a point where this person's complaint behavior is unreasonable? And is there any guidance out there which people can refer to?
I think there are a few things with that. I think, first of all, it's about applying the right threshold. So you've got to separate people who are asking questions that are answerable, that you've not already answered, but are persistent and frustrating because you consider there may not be a lot in the complaint. I'd say those you try and answer as much as possible. There are those situations where you simply get the same issue complaint, the same questions again and again, and the complainant simply does not believe your response, in which case that's where you'll be drawing a line underneath it and directing them to the Ombudsman, essentially saying, look, we've looked at your complaint very carefully. We don't think we can add to that response. You've asked these questions, we've answered them previously. These are your options if you remain dissatisfied. So those are the things that get on. There can be issues in relation to ongoing behavior outside the complaints process that can put a strain on the doctor-patient relationship. And as I say, you've got to be really careful that it's not simply because they've complained, but there can be some circumstances where the complainant may not be able to get beyond a delayed diagnosis, even if it wasn't anybody's fault, or if an error has happened, can't get beyond that, where you may need to have that discussion about whether they are better off served elsewhere.
Yeah. I'm not able to see any other questions, Ed, maybe because I've had IT problems. Is there anything else that struck you as being?
So I've got this one that I think we actually dealt with in the presentation of how do you use complainant uses racism as a basis of a complaint. I think that works two ways. As we said, we dealt with racist comments being made in a complaint, that you can certainly deal with those under your behavioural management policy. If there are others where the allegation is that the patient has been discriminated against, your best bet is to really set out the care they have and explain why that was objectively justified. It's difficult to do anything but simply deny there was a racist motivation, but simply explain, and we do see this sometimes where people might be asked about where they grew up, and an explanation as to why that question is relevant might be what's necessary to kind of deal with why that question was asked. So I think it depends, but that's the basic approach to it.
I think that's probably enough for the questions and the time. So I'll let you wrap up, and then we can let everybody go and enjoy their evening.
Well, thanks, Jared and Sarah, for your contribution today. I hope you guys on the webinar found it helpful. I'm really sorry we didn't get to all the questions and the glitch, but really thank you for your time this evening, and thank you for joining us, and watch this space for future webinars.
Thank you.
Bye-bye.
Bye-bye.
Bye.